to discuss your practice and performance over the previous 12 months, and for you to compare your practice to a set of standards which we all know are listed in good medical practice. Can I have a show of hands as to who's read good medical practice? Okay, yeah, it's probably worth having a little look, because they always refer to it when it comes to standards, yes, but have a rough idea of where it is or how you can access that document. Another purpose is to enable doctors to enhance the quality of their professional work by planning their professional development, and this normally comes in the form of an agreed personal development plan. A bit of repetition in number 3, to enable doctors to consider their own interest in planning their professional development. So in other words, when you decide your priorities, there will be a combination of things that you want to do for yourself, you want that may benefit the practice, that may benefit the wider community, that sort of thinking. If you're working in a hospital setting and having an appraisal, the last point becomes a bit more relevant, to enable doctors to ensure that they are working productively and in line with priorities and requirements of the organisation they practice in. So for example, if you're in a trust and you have your annual appraisal and you set an objective which is not aligned with the trust or your department, you may find that the appraiser wants to sort of emphasise that, is this an appropriate learning need or not? And it's all about negotiation. You might think, yes, ultimately patients will benefit from this, but you may find that it is not in line with the department's priorities. They may not support it, i.e. they may not fund it. So be careful about that. So moving on to revalidation. What is revalidation? So we know that this process is set up to assure patients and public and employers and other health professionals that licensed doctors are up to date and fit to practice. So the important thing to remember is that it's all about the license. Okay? So once you obtain your CCCT, you will get a license to practice, and that license needs to be renewed every 5 years. Okay? So in other words, the essential difference between appraisal and revalidation is that revalidation is an administrative process of giving a license and withdrawing a license. Appraisal is a formative, supportive process which has a summative component. So appraisal feeds into revalidation, but is slightly separate. Does that make sense? Yes? So you have to have an annual appraisal in order to be revalidated. So when you join the performers list, have you heard of the performers list? You will be sent an automatic email from the organisation that you're joining, your designated body, that you have joined the list, and then you will be nominated an appraiser. Okay? And the idea is that you contact the appraiser, you'll be given a rough date or a month of your appraisal to say that. So let's say you join in April, you may get an email within the 3 months of joining to say that your revalidation date is June 2018. Okay? So the idea is that you make contact with your nominated appraiser a few months before that date, agree a date within that month, and then start preparing the supporting information to give to your appraiser at least a minimum of 2 weeks before the actual date. Is that okay? Happy with that? And what I'll do is I'll cover the sort of information that you want to gather. In terms of electronic toolkits that are available to gather that information, have you heard of Clarity and the RCGP tool? Seems to be a normal transition for GP registrars to transition into that, so that's one tool. But there are other ones, such as GP Tools or the MAG, which is called the Medical Appraisal Guide. Okay? So the important thing is, if you're not sure which tool to use, ask the team. You don't want to go off and use something that might not be user-friendly or approved by the responsible officer. So this slide is a little bit busy, but what it does is it tries to summarize the process of what medical appraisal is. So the important thing to remember is that appraisal covers the whole scope of a doctor's work. So in other words, if you have a number of roles which are outside your mainstream general practice, then you need to bring relevant information to your appraisal. So for example, let's say you do out of hours, or let's say you do some A&E sessions. Any extended role which requires a license to practice, you need to bring some information which demonstrates that you are keeping your knowledge and skills and fitness to practice in that role. Is that clear? So I'll give you an example. Let's say, so let's say you're a portfolio GP, yes? You do some out-of-hours sessions, you do some A&E sessions, and let's say you do a bit of cosmetic work, yes? So in each of these roles, you need to demonstrate fitness to practice. And the idea is that over a 5-year period, you would bring information into your appraisal which covers these roles. You may find in some of these roles you have a formal appraisal system. Let's say you're a hospital post. You may say that you have an annual appraisal in your hospital post. It doesn't mean that when you come to your GP appraisal that you have to have another appraisal in this post. It means that you should bring the outcome of that discussion to your appraisal discussion. Does that make sense? Am I being clear there? No? Yes? Okay, lots of blank faces. People not moving their heads?
Yes.
Yes, okay, good. So, if we look at this process on the left-hand side, you've got the stuff that you're going to do. In other words, what you do is you bring information relating to the nature of your work, you bring relevant supporting information, you bring your last year's PDP. So this is quite important because when you have your final meeting with your trainer, your final meeting, you agree a PDP, don't you, a personal development plan. Yeah? So it's important to make sure that's quite relevant to your job that you'll be starting, because when you have your first appraisal, the appraiser will be looking at that PDP. Yes? So don't forget about that appraisal, don't forget about what that PDP is, because that PDP is quite relevant. So when you meet with your trainer for your last meeting, yes, which is like a mini appraisal, agree a smart PDP which is relevant to your work that you're doing, okay? Because that will be discussed at your appraisal. Obviously, your achievements, challenges, and aspirations you bring to your appraisal discussion. The discussion itself has an essential, it's confidential within the bounds of the GMC regulations. Yes. So there's facilitated reflection. There's a 2 to 3 hour discussion. There's a bit of challenge about, you know, the appraisers moving you from where you are to where you want to be, or where you could be, or where you should be. So there's always that element of challenge, a supportive challenge. At the end of the appraisal discussion, what happens is that you agree a PDP, there's a summary of the appraisal that the appraiser writes up, and then the appraiser signs off particular statements, which I'll come on to, which are quite relevant for the process of revalidation. So just to clarify, this process happens on an annual basis. Okay? Your role is to gather information over the 12 months which reflects your ongoing professional development. So, let's take one step back. When did revalidation start? Anybody know? 5, 6 years ago? Yeah, roughly around December 2012, that's when it started, okay? So, before that, the GMC had obviously developed lots of information to support revalidation, and what they wanted to do was to say that, look, for doctors to be revalidated, they need to collect information within 4 domains over a 5-year period. Knowledge, skills, and performance, safety and quality, communication, partnership, teamwork, and maintaining trust. Are these familiar to you? Yes? Because they transact in terms of your training, in terms of your curriculum, there's lots of crossover there, yes? So the GMC set these domains, and then they said, we want 6 types of supporting information which supports these domains. And this is evidence of continuing professional development, evidence of quality improvement activity, evidence of significant events, feedback from colleagues, feedback from patients, and review of complaints and compliments. So this is the core of the information that meets the requirements for revalidation. And this is information, some information you'll collect on an annual basis, some information, as we'll come on to, you'll collect once in a 5-year period. Okay? So let's look at, so what I'll try and do is I'll compare, because if I just take one step back, every specialty has a slight variation on what the GMC has set. So GMC has set some generic requirements for revalidation, but if you're an anaesthetist, if you're a surgeon, your college will tweak those guidance because of the slight difference in the specialties, yes? So our guidance has been tweaked by the Royal College of GPs. So a very important document to read is called the Revalidation Guide for GP, RCGP Revalidation Guide for GPs, which was published in April 2016 and it's available on the RCGP website. Right, so a very important document to put on your reading list, yes? Because at least you'll know exactly what the standards are, what you should be aiming for. So what I'm going to do is I'm going to look at each one of these types of supporting information. This is obviously a plant by Andy. Andy, who's Emma Bravery? Let me just send her a message. Don't worry, I'm busy. Okay, anyway. I'm sure he's having a laugh at the back somewhere. Okay, so let's move on to continuing professional development. We'll look at it from different perspectives. So the first one is the GMC perspective, the second one is the RCGP perspective, and the third one is what your responsible officer expects. So this is what the GMC expects. And it was Emma Bravery called. She says, is it okay to meet for a cup of tea later on, maybe? Okay. Sorry folks, so GMC said there should be a discussion on your CPD at each appraisal meeting, and this discussion should cover these points. How do you keep up to date? How do you identify what you need to learn? Is there evidence of reflection? What have you learned, basically? Yeah, very bog standard stuff for you folks, because you're all reflective practitioners. Yes? Reluctantly. Okay, so this is what the RCGP says. The RCGP says, look, you're supposed to accumulate 50 CPD credits a year. Each credit is 1 hour of learning activity demonstrated by a reflective note on lessons learned and any changes made. So, and once you've demonstrated, this is important, once you've demonstrated 50 CPD credits, there is no need to obsessively document or write reflective notes on every learning activity you undertake. So that's reassuring, because in the past, we'd ask 200 credits, we'd have 150 credits to say, look, how good am I? I'm wonderful because I've done 100 credits. And it used to be quite challenging as an appraiser trying to go through all these CPD credits. So the reassuring thing is, you just need your best 50. Does that make sense? The best 50 that reflects, good reflection, good impact, good change in practice. Is that okay? Question there. So I was going to take questions, but because you raised your hand, I forgot. Don't tell me.
Is that everyone here?
It is everyone here.
Rashba,
Yes.
can I interject as an appraiser?
As an appraiser, okay. As long as it's not a difficult question, Mike.
No, it's not a question. I'm actually making a statement. I would always encourage appraisees to reflect as they go along. So you are going to, I think, reflect on all your learning activity. What you then choose to present in your appraisal documentation will become apparent as the year goes on. But obviously, if you choose your topic at the end of the year and you think, what the bloody hell went on with that? It's not going to work. The reflection needs to be recorded sort of at or soon after the time of the activity. That I think is from an appraiser's point of view is helpful.
Yes. I'm happy to take questions at the end, unless you think it's really relevant to this. Okay. Reluctantly so. Okay. Okay, folks, so Mike's always right in what you said, but it doesn't mean you don't still reflect, but pick your best 50 reflections, and after that, you don't have to record them. So what does the RO expect? So this is important. It's important to be aware that the requirements do not differ by work setting. So let's say, for example, you do 1 session a week. Let's say you're a full-time doctor. Let's say you're a locum. The requirements are the same. Does that make sense? It doesn't mean that just because I do 1 session a week, I should just have a 1/5 of the CPD requirements in a year. That's not the case. 50 is the minimum, no matter what the work environment is. Okay? So let's say, in order to be on the performers list, how many clinical sessions do you need to do a year? Okay, so the correct answer is 50. But if you were to really scrutinize it, the real answer is nobody really knows. Okay, because it's not really written in stone. So you may find it varies from area to area, but the responsible officer in this area has set a limit of 50 clinical sessions a year to stay on the performance list. If you stay on the performance list, then you have an annual appraisal. If you do less, you go off the performance list, and you don't have an appraisal, and you're not going to be on the track for revalidation. Okay? The other important point that the RA expects is this appraisal must cover the whole of a doctor's practice. So in other words, at the appraisal, GP appraisal discussion, you bring in all your other roles that require a license to practice. You may do some voluntary roles that don't require a license, that's fine, we don't need to know about those, unless you want to share that information, but only those that require a license to practice. Be it, I support my local football team, I'm the doctor at the site, medical doctor there, that requires your license, you need to bring relevant information about that.
Does that include if it's voluntary as well?
If it's voluntary and requires a license to practice, yes. Okay, mandatory training, this is quite important. So inclusion in the performance list requires that GPs have an up-to-date level 3 child protection training. So level 3 child protection training is valid for a period of 3 years. And the idea is that what you should do on an annual basis in between that period is that you should be doing some level of CPD, yes, because if you look at the detail, there's a document produced by the intercollegiate document produced by the Royal College of Paediatricians and Royal College of GPs, which says that GPs have certain levels of competency at level 3, which they need to maintain or demonstrate that they need to maintain. So you need to still do CPD, at least a minimum of a couple of hours a year, and then update your level 3. Adult safeguarding and CPR training are not absolute requirements to be on the performance list, but CQC has a different point. If you have a CQC inspection and you're working there as a locum, they will ask you when your last CPR training or adult safeguarding was. And they would expect it to be renewed every 12 months. Happy with that, folks? Quality improvement activity. This is what the GMC expects. So quality improvement activity should be robust, systematic, and relevant to your work. They should include an element of evaluation and action, and where possible, demonstrate an outcome or change. So this is the basis of any quality improvement activity. What does the Royal College say? Doctors must provide evidence of quality improvement activities in every appraisal. So in other words, annually, these activities should reflect and demonstrate how you review and improve the quality of your work every year. Examples might be audits, a review of outcome data, for example, referrals, significant event analysis, PDSA cycles, reflective case reviews. Okay, so there's a broad list of things that you can classify as quality improvement activity. The important thing is, if it looks at something, identifies areas of improvement, demonstrates change, then that's a quality improvement activity that you can include. There's no fixed number of QRAs, but it must cover the whole scope of your work over the 5-year period. So that doesn't mean, let's say if you're in, we had that example where you do cosmetics, you do out of hours, you do other roles. It doesn't mean that you have to bring a quality improvement activity every year in each of these roles. Over a 5-year period, you should bring at least one quality improvement activity in this role. But in your main GP role, your GP job, which you do, you should provide quality improvement activity on an annual basis. We're clear with that? Excellent. So what does the RO expect? Although the new guidance is, actually the RO is a little bit frustrated by the new guidance, actually says, although the new guidance is on the face more flexible, it does make it harder for me to set that clear line in the sand of what meets the requirements. Before the guidance in April 2016, the requirement was that you do a full cycle audit in a 5-year period. But now, it's a bit more vague. You do quality improvement activity, which you decide what you want to do on an annual basis. So it's a little bit more vague. So the RO says, however, I expect some quality improvement activity on an annual basis. And if you're not sure what that is, refer to the RCGP guidance, for example. Significant events. You should discuss significant events involving you at appraisal with a particular emphasis on those that have led to specific change in practice or demonstrate learning. There is a slight confusion here. So significant events at the GMC level are often classified, especially within a trust setting, as serious untoward incidents. These are incidents, unintended or unexpected events, which could or did lead to harm or one or more patients. So this is the GMC level significant event. Most of us, touch wood, will not have one on an annual basis. So you can sign a declaration to say, I've not had one. On the other hand, you may have an unexpected death, you may have a serious drug error, a prescribing error, which results in an admission of a patient. Then all those things which you have to declare to NHS England are classified as GMC level significant events. On the other hand, There are events which are below that threshold, which we still expect you to record. For example, you know, prescribing, you've got the wrong screen up, you prescribe to the wrong patient, you know, it's classified as a, not GMC significant event, but a significant event. Those things you can continue to record, but you view them as quality improvement activities. Is that clear? Are you happy with that? Because sometimes there is some confusion with that.
Can you do ones that you're involved in, say you pick up that someone else has done that, but then you're involved in the whole process of doing the significant events analysis? Because quite often there's more than one person in discussing. There might be 6 or 7 people discussing a significant events analysis.
Yes. The short answer is yes, you can. Okay? As an appraiser, I might challenge you, for example, on a year to year, you keep putting in other people's significant events and none of your own. Okay? So that's my challenge that I would do. Okay, so again, what does the RO expect? Before the April 2016 RCGP new guidance, the requirement was at least 2 significant events a year. That requirement has been removed. The revised requirement, as I've already said, is GMC level significant events which you are personally involved. You should include reflections. These are uncommon and rare. You must also include all complaints in which you're personally named or involved. There will be lower level ones that we discuss, which you include as part of quality improvement activity. Which is basically reiterating what the RCGP said. Happy with that, folks?
Can I just clarify something?
Yes.
So, a significant event that's basically not at a GMC level
Yes.
is a QIA number.
Yes.
Right? So do you have to have done, that says you don't have to have done a minimum amount, but if you, so if you could essentially just go a couple of years without having one, there's nothing.
Yeah. You could do that, but remember, on an annual basis, you have to include quality improvement activity there. But when regards to significant events, you don't. There's no fixed number. If you do record it, it's part of quality improvement activity. Question over there.
They do online clarity.
Yes.
Where do you put it then? If it's not a formal GMC SEA,
Yes.
you still put it in the SEA?
You can put it in the SEA, but you don't have to sign a declaration which shows that you've got a GMC level significant event.
Okay. And then when they look at you, because then it might not come up under the quick, like...
It will be counted as part of, in terms of CPU points, you can still claim for it, but don't worry too much about whether it comes under quality. To be honest, it's semantics
You
really.
wouldn't have to record it twice.
No, definitely not. Definitely not.